This is Tanda Gatlamini on this day, January 14, 2025, in Washington D.C., conducting the interview for the Global Oral History of PEPFAR project. Could you please, Ambassador, begin by telling us introducing us to yourself and establishing your connection to PEPFAR? When did you start working for PEPFAR, and what years that was? And yeah.
Sure. Well, thanks for doing this project. I'm Jimmy Kolker. I was ambassador to Uganda 2002 to 2005, and of course it was 2003 that PEPFAR was announced by President Bush, and 2004 that we got the first programming money from PEPFAR. And so I was very much involved in the launch of the PEPFAR program in Uganda, which at the time was actually PEPFAR's showpiece. It was designed with Uganda in mind. So we had a lot going on and a huge number of visitors, very comprehensive HIV program in Uganda, and I'm pleased to talk about it.
Thank you. So could we just begin by you telling us briefly about yourself and your family, where you were born and where did you go to school?
Sure. I was born in St. Louis, Missouri, and I went to public schools in the suburbs of St. Louis, then went to Carleton College in Minnesota, and generous taxpayers paid for me to go to graduate school after I joined the Foreign Service at Kennedy School at Harvard. So I have a Master in Public Administration from Kennedy School. And my wife, Britt-Marie Forslund, is a Swedish politician. I used up my option in the diplomatic service of marrying one of my political contacts. And it turns out it's not a very portable career, so she's done a lot of things in the interim. But we have two daughters, both adults now, Anne and Eva. And we actually have a Ugandan member of our family who we met when we were living in Uganda, who's living here now and has become an American citizen, arrived in 2013 to the U.S. As an adult. He's 33. I started in the Foreign Service in 1977, and as I was mentioning to you, my first post was Mozambique, and then I helped open our embassy in Zimbabwe in 1980. Served in Sweden, in the UK, then was in management. I was Deputy Chief of Mission in Botswana from 1990 to 94. In Denmark from 1996 to 1999, was number 2 at the US Embassy there, and then got to be ambassador twice, first in Burkina Faso in West Africa, and then in Uganda. And when I left Uganda, I became the Deputy Director of the PEPFAR program here in Washington. I did that for 2 years. I then was offered the job as head of AIDS at UNICEF in New York. So I worked in the UN system and at the UNICEF New York headquarters in New York for 4 years. They have a mandatory retirement age in the UN, so I had to leave there. But I was then offered the job as Assistant Secretary for Global Affairs in the U.S. Department of Health and Human Services. So I worked in global health from the health ministry side from 2011 to 2017.
Oh, wow. That is quite an experience, especially working in foreign service and in Africa, which is really exciting for our project. So I think because you have spoken about your career, maybe like really from the beginning up to now. So how did you come to work to PEPFAR? Well, HIV issues first, and then PEPFAR specifically.
Well, first I have become, in my later years, known as America's AIDS and health diplomat. And I have no credential for that job. I am not a health specialist. I have no clinical or medical background. But I kind of backed into it when the PEPFAR program was designed. The structure, which I was thrilled about, said that it was ambassadors and country teams at posts overseas who were responsible for setting priorities, picking partners, allocating funding, and accountable for results. And this is something I'd wished for in my Foreign Service career. But I am not a development professional. I was a political reporting officer for my early posts. But I saw an opportunity to really make a difference. And Uganda, prior to the time of PEPFAR, was kind of the epicenter of AIDS in Africa. And so every family was affected. It was already a major part of our embassy program before PEPFAR. But this gave us an opportunity to scale up. And whereas the health programs up to PEPFAR had been proofs of concept or pilot programs or centers of excellence, often at just one site, suddenly we had this opportunity that was national scale up. We needed to reach everyone in Uganda who needed help. And we already had the names of about 50,000 people who were in care and were eligible for antiretroviral treatment. But we imagined that there were about 100,000 more in Uganda. So our goal for the first couple of years was to reach 150,000 people with antiretroviral treatment. And I also realized that while we had terrific people at CDC and at USAID in country, and they actually were an outstanding team and already, as I say, doing very good work, it turned out that National Scale Up is different than the kinds of programs that they'd done before, because you needed to look at supply chain, you needed to look at political issues, there was conflict, certainly economic impact, there were sociological issues, ethical issues about scaling up. And so just the management of that program required some diplomatic skills, which I realized from the Foreign Service career we actually could bring to the public health goals. And I am proud to say that I think Uganda was the first to kind of realize that we mobilized the entire mission at the U.S. Embassy in Kampala to try to make that PEPFAR program succeed, and we were able to reach our targets, which was quite remarkable.
Indeed. So then you get to be appointed. I'd like to just know, like, getting appointed. So because you said that you were working in Mozambique prior to Uganda, that's correct?
Yes, though, 2 decades
so
prior,
you already
yes.
had some experience with Africa. So so when PEPFAR gets mentioned that the president has launched PEPFAR, I mean, where were you at that point in your life, and I mean, how did that really resonate with you?
When President Bush made the State of the Union address, I was ambassador to Uganda, and we had had a little bit of warning, although no advance information about his announcement. But Jonathan Merman, who was the head of CDC in Uganda at the time, and I hope you'll be interviewing Jono, he came to me and he said, we're being asked for data, for something's happening. We're being asked, there are unusual data calls and they're asking for information which we've supplied before, but this is different. It seems to be much higher level, much more immediate requests for facts and statistics. And he said, something's happening. And that was about a week before the State of the Union address. But when this actually happened, we were all astonished. We couldn't imagine that this was a multi-year commitment of $15 billion, and how much the president highlighted it for the right reasons. It was because this is what we needed to do. This was morally imperative, that because we had treatment that was available to Americans, that we helped make that treatment available to people who needed it in Uganda and other countries.
So I see that you have been in Africa prior to PEPFAR, as you've rightfully mentioned. So you've been there prior and after, because before treatment was there, you know, things were really tough. Can you explain to us how
I
it
was in Botswana, as I said, from 1990 to 94. And it was a time when AIDS was just reaching Botswana. But we knew, for instance, the doctor with whom the embassy consulted had HIV positive patients, and she was telling us about them anonymously, but how serious this was and how we needed to be paying attention to HIV. And the CDC did open an office in Botswana while I was there, but they were concerned with tuberculosis, which is of course connected to HIV, but that the whole health system was being affected by the introduction of HIV to the country and the fact that it was reaching elite populations as well as neglected populations. So I had certainly some knowledge of that and concern about HIV long before I came to Uganda. This was in the early 1990s. And it was especially poignant in Botswana because shortly after we left, the ambassador of Zambia, who was one of my best contacts when I was number 2 at the embassy in Gaborone, was a good family friend, died of AIDS. And we hadn't really, it came quite suddenly. We realized that the last few months we were there that he was very sick, but didn't realize it was HIV and AIDS. And then just a few months after we left, he passed away. So I had a very vivid experience of someone who was one of the earlier victims in Southern Africa.
So would you say, I mean, as the ambassador in these different countries, and when HIV was popping up, did you have like visits where you can be able to see how it was really affecting the societies, like your own personal experience, except that one of the friend in Zambia? Like, I just want to be able to tell like the gravity of it prior and after that, what you witnessed, especially like across the countries. Were there any variations? Was there another country where it looked much worse than the other, or based on statistics or what have you?
Well, of course, I went from Botswana to Europe and then to Burkina Faso. And in Burkina, AIDS was already affecting the population, both in terms of what they called sentinel surveys, which actually wildly overestimated the HIV-affected population because they were testing women in maternity clinics, who of course were by definition having unprotected sex and were an especially vulnerable group. And so we did make HIV a priority in Burkina Faso, but we had no money to support it. Literally, there was a collection around Christmas time from embassy employees to help a group of AIDS orphans that who had lost a parent to AIDS. And we were the host in Burkina in 2000 of the Africa Conference on AIDS and Sexually Transmitted Diseases, and ICASA. And that was a chance to wake up the government there that they had a problem, to get the president, and I was involved as U.S. ambassador along with other ambassadors in getting President Compaore at the time to talk about AIDS, to appear at the conference, to be on billboards, advising people to change their behavior and what risks HIV was causing. But in my sort of official capacity of running a U.S. program, we didn't have AIDS on our agenda for bilateral cooperation. There were some groups of donors that were meeting from time to time, and I participated. We didn't have a USAID mission, and except for the first year, we didn't have any CDC people in the country. So I often represented the United States as ambassador at donor meetings, and we talked about AIDS. We talked about the initiation of the Global Fund, which was the last year I was in Burkina Faso before PEPFAR. But so I was well aware of the issue, but I have to say that it was just one among many issues that we dealt with, for instance, in Botswana and Burkina Faso.
Thank you, Ambassador. We know that, as you've also rightfully mentioned, that at the beginning there were a couple of U.S. missions that were going to Africa to learn about HIV, and Uganda being one of the epicenter where the response to HIV was mostly picked up from. So, I mean, I know there's Zimbabwe, there's Botswana, Burkina Faso, there's Mozambique. I don't know if some of these missions you'd like to highlight to us, like when they were coming on board, what were they really looking for?
Well, there are two very important ones. After President Bush's State of the Union message in 2003, he arranged two victory laps before the program even started. And the first one was in July of 2003, and President and Mrs. Bush came to Uganda, among other African countries. But and Uganda was, I think, the third of four stops on their trip, especially focused on AIDS. And he didn't spend the night in Uganda. We actually had a visit that lasted only 195 minutes to Uganda. We couldn't bring him out of Entebbe, which is where the airport is, even to Kampala, the capital. But he met with the president at bilateral visit. But we had assembled at the TASO office in Entebbe, the AIDS Support Organization, TASO. We brought all of the partners we were already working with and who we anticipated working with, expanding our cooperation with PEPFAR, at a kind of job fair almost. There were different booths representing testing, representing people already on treatment, representing research, things that were going on in Uganda. And there was a lot going on. There were a lot of wonderful partners we had. But this was organized by TASO, but including all of our Ugandan partners who presented themselves to President and Mrs. Bush and to Condoleezza Rice, Colin Powell, and others who were on that trip. They came on Air Force One. And then President and Mrs. Bush, but not myself, but just a very few, were able to go to see an individual who was very, very ill with AIDS, who exhibited many of the symptoms and characteristics of people who were losing their lives. And it was someone who it turned out died only a few days later. And it was clear that they all mentioned how much they were affected both by the presentation of the different organizations, but especially by seeing the patient who was personally doomed because of the disease. And President Bush gave an address outside of the Tasso office in Entebbe, and then asked my wife and me to join them in the limousine for the trip back to the airport. And again, this is presidential history. The presidential limousine, and they fly in two of them. We had, it's actually the 195-minute visit by President Bush had a budget greater than our entire embassy operating budget for the rest of the year, because they had to fly in so many different things, crews, divers in case this plane was for some reason in Lake Victoria and so on. But this limousine is like a London taxi. So the Bushes sat at the back facing forward, but there were these fold-out seats facing them in the back seat area. And so my wife and I were pre-positioned in these fold-down seats, but then we hadn't remembered that one of their daughters, Barbara, was with them on the trip. And she, of course, had been in that seat normally. And so the Bushes walk in, and Barbara sits on the handrest in the middle of the back seat. And so it was all very friendly, but he said, what he said during that short drive to the airport was very, very important. The first thing he said is, you're doing things here that they just told us in South Africa were impossible. And that was to put people on treatment and keep them on. And then he said, and it only costs $30 a month? We said, yes, we were using generic drugs then in the pilot program. And he said, and all you need is money? I said, yes, sir. He said, don't worry, you'll get it. And with those 4 sentences, I'm still almost choked up to think about how, first, he got exactly the message we wanted him to get in Uganda. And this pre-PEPFAR, PEPFAR was announced but hadn't been implemented. But that's exactly how it should work. It's exactly why Uganda should have been the showpiece and was ready to go. And he got it and was able to repeat that back to me in a very short conversation that was so perceptive about what was going on and what we needed to do. And that assurance, don't worry, you'll get it. Those words are still ringing in my ears, because that was the assurance we needed. There are so many reasons in the U.S. government experience that you announce good intentions and you even announce a budget, and then it never gets to the field. And so it took a full year after the State of the Union message. We didn't get any treatment money until March of 2004. But that assurance in July of 2003 meant that we really moved ahead with our program and assumed we were going to get the money we needed. The second of the preliminary trips, again, a victory lap before the program even started, was Secretary of Health and Human Services Tommy Thompson brought a huge delegation to a number of African countries in December of 2003. And this included people from the private sector in the U.S. like Richard Holbrooke, the head of CDC, the new head of the PEPFAR program, Randall Tobias, but also the head of the Global Fund, the head of the UNAIDS, and a lot of people who were involved in the AIDS response. And in that capacity, we took, it was logistically quite difficult for a couple of reasons. First, it turned out that there was some reason that the group couldn't go to Kenya. They'd been in Rwanda, and they were supposed to go to Kenya for a day and then to Uganda for 2 days. And the group that was supposed to go to Kenya had to get a separate small plane. They were on one of these big U.S. government planes. Had to get a separate small plane to Kenya. And of the 105 people on the delegation, 80 of them came to Uganda a day early. We found out at 6 o'clock in the morning that you were about to have 80 VIP visitors about 10 o'clock this morning, 4 hours notice. And the embassy came through just remarkably well. We found hotel space for them again in Entebbe because we couldn't find space in the hotel they were going to live in Kampala the next night. And then we had to arrange a program for that full day. And it worked out so well. We got the Minister of Health to go to the JCRC, the Joint Clinical Research Center, had Dr. Peter Mujenyi, who was one of the original sponsors of PEPFAR, the only foreigner who was at the State of the Union message when President Bush announced the program. But we had Peter Mujenyi talk to them. We had the Minister of Health talk to them on the JCRC grounds. We took them to a clinic, and I had a big reception for them that night. And believe it or not, we got about a dozen Ugandans to turn up on very, very short notice. And you can imagine an embassy first just having logistically to deal with 80 people traveling for the hour between Entebbe and Kampala and arranging a full program, and then figuring out how we were getting all these people to perform for them. But it almost to a person, whenever I've seen those people again, they remember that day vividly. They remember being at the residence, and they say it was the best day of the trip because it was so spontaneous, and they were themselves. This wasn't a stage show. These were people who were just called to talk about what they cared about because this wasn't rehearsed. It wasn't pre-planned. So we then got the rest of the delegation, and we had a marvelous program because I had insisted, and this is maybe important for presidential history too, the HHS advanced team, I'd insisted they go out and actually see the people, the only people in the world at that time who were getting HIV, who were getting antiretroviral treatment at U.S. government expense as part of one of our programs. But this was located in Tororo, which was a very tough 3-hour drive from Kampala. And we had 105 people. And the idea was that they would actually meet these individuals who were getting the treatment as part of a home-based AIDS care program, HBAC. And again, Jonathan Merman and Becky Bunnell know it very well, and I know you'll be interviewing them as well as Rob Cunane, the head of USAID in Uganda at the time. But this program, the advanced team that had come for Secretary Thompson said, this is too complicated. We can't get all these people to Tororo. This is going to be a mess. And what if something goes wrong? They have such a tight schedule and so on. I said, no. I actually went back and talked to Bill Steiger, who was the head of the Office of Global Health at that time at USAID and was Thompson's guy. And I said, you have to overrule your advanced team and get them to Tororo. That's the reason they need to be in Uganda, to see what HIV treatment can do. And so they luckily took my advice, and I was pleased that the program went relatively well. There were a number of snafus, but as usual, the purpose of the program was absolutely accomplished in that every member of that group, in groups of 2 or 3, went to visit 2 HIV positive people in their homes. And again, you can imagine the logistics of trying to get 50 different groups to be going out to see HIV people, and 100 of them agreeing to meet with foreign visitors. But everyone in that group, again, remembers exactly what it looked like, the names of the clients that they saw, and how miraculous this was. These were people who were getting antiretroviral treatment and talked about their own experiences and how they were near death, and they now are living normal lives. They're able to cultivate their fields. They're talking about raising their children and so on. So both of those trips turned out to be really important in getting PEPFAR off the ground in Uganda, both because we had our partners involved in talking to the high-level people who were visiting Uganda, but also because our own team realized that this was going to work, this was possible. And we really were on to something. This was so much needed, and that the U.S. was offering something that no one else was offering.
Wow, that is quite remarkable. So many people overnight, impromptu, but still everything is seamless. That showcased a great deal of skills on organizing and leadership skills. And I think I'm just also intrigued by the fact
we had
that
a terrific team. We really did.
yeah.
In fact, I should mention Richard Holbrook, who, as you know, is not known for understatement or humility, grabbed my arm, grabbed it really tight in my bicep, and said, "Jimmy," we'd known each other a little bit before, "Jimmy, this is the best thing any embassy has ever done." So I knew that was probably not true, but that was our feeling at the time. This was exactly the right thing to do. And this was out in Truro. This was after he'd been to the home of one of the HIV positive people.
Thank you, Ambassador, for sharing that experience. So this mission coming through, I know that at that point, PEPFAR is new. There's going to be so many resources coming in to Africa, and there were some concerns about this particular program going to Africa. The treatment, was it feasible? Like you just mentioned, in South Africa, they were like, it's not possible. So what were they really looking for, except for like maybe seeing people that are practically infected with HIV/AIDS, like on a system level, like hospitals, were they interested in systems, expertise? Did they speak to doctors as well, health administrators, or not?
Well, these delegations did, but at obviously a very short visits and superficial level. And PEPFAR, one of the things that made it really exciting for me was that they left it to the posts to determine who these partners were. How are you going to, here are your goals, here's our timetable, here's how much money you can expect, but you figure out how to do it. And that was, again, to me, I saw that as empowering to the missions in the field. I have to say that the majority of ambassadors in that situation didn't seize the moment and said, well, this isn't something ambassadors do, we'll leave this to the aid mission, or this is too hard, or we don't really know how to do this. And local partners were not as well organized as they were in Uganda. The program was designed with Uganda in mind. Peter Mugeni was there. Tony Fauci had, as you know, a lab in Rakai in Uganda, which I had visited, and I knew Fauci well because he'd visited there. And these NGOs, the TASO and especially TASO and JCRC, were world-class organizations dealing with AIDS at the community level, and had all these clients already identified who were already eligible for treatment, were getting everything short of treatment. So we were ideally positioned in Uganda to be the lead country. But we also, I'm proud to say that we recognized the opportunity that PEPFAR provided, which really was unique. And as I say, the majority of country teams and ambassadors at the time didn't. And we were the only ones the first year that met our targets. And we actually got extra money because we were showing results from the very beginning. And that, to me, is a point of great pride, that there are a lot of people alive today because we move fast.
Of course, Uganda did showcase this in many ways, and I think it's very rewarding to know that you are behind that success with your great team, of course. Ambassador, could you please just tell me, so PEPFAR is announced, and you have that assurance from President Bush on that brief drive to the airport, and of course there's a bit of time lapse before you can actually get the resources. So what do you do as the ambassador, like, after that day, like, to make sure you prepare for this money that's coming?
Right. I gave you an incomplete answer to the previous question, but it affects this one also.
Oh, okay.
First of all, I've thought about this a lot and even written an article about the early days of Uganda from the point of view of science. That every peer-reviewed journal article starts with assumptions being, well, none of these drugs have been used on women of reproductive age. None of them have been used on adolescents. There are no children in our trials, and so on. And a lot of assumptions about how the experiments would work, and then ends with the sentence, more research needs to be done. And that was certainly true for the antiretroviral drugs. They were very powerful drugs, and normally you would do a longitudinal study. You'd have these drugs administered to people for 5 or 10 years find out what the side effects are, see if these were as effective as you wanted. Of course, in AIDS, we didn't have time for that. We needed to start the program right away. But as ambassador, you're assuming a lot of this risk. And how do you manage this risk? The risk that these people, in the US, these drugs we knew were effective, but these were people, the treatments cost about $10,000 per person per year. They were supervised by specialist physicians in specialist facilities. They had annual tests of viral load and CD4 to determine whether the drugs were working. These tests themselves were expensive. They were not available in most parts of Uganda. In Uganda, the people we were trying to reach lived in rural areas. Many of them were undernourished because they stopped farming or stopped eating because of their medical conditions. They, you may remember Andy Natsios, the head of USAID at the time, said, we think people have to take pills at specific times in each day, and Africans aren't used to doing that, which is true. There was not a sense of keeping to a very fixed schedule of treatment, which we thought at the time it turned out not to be true, but that it was very important to take those pills at the same time. And of course, there were none of these specialist doctors and nurses in the areas where we would have to scale up treatment. And the question is, how would you know if there were treatment failure? How would you know if there were side effects? How would you judge if a patient needed an additional intervention, something else? And so we had to solve all these problems on site. There was no global solution to this question. And we did, as they'd used in the HBAC program, the home-based AIDS care program that they visited in Tororo. You had high school graduates, not medical professionals, with clipboards riding motorbikes who visited these patients every other week. And they had a list of proxy indicators. Do you have a rash? Have you had a headache? Do you have nausea? How are you feeling? What are you better? Are you able, can you do certain functions? Can you walk around? Can you tend your fields? And it turned out that those proxy indicators were 95% effective in finding if there was some kind of treatment failure or serious side effects that needed to be dealt with, and that the local physicians who were trained in looking for AIDS-related conditions, but were not the kind of professionals that American patients would have had, that they were able to deal with those side effects. And once we started the program, it turned out that our assumptions were very much justified, that Ugandans were more adherent to treatment than Americans were, that the results were superior because they hadn't been self-medicating. Many of the American patients had tried different experimental treatments over the years. And so the Ugandans were naive to treatment, as they called it. And so the drugs worked exactly as we hoped they would. And the demand for this care, once it was introduced on a more widespread basis, was every person I ever met, I think, in Uganda said, I have a cousin, my brother-in-law needs help. How can I get them into a treatment center? And so the word spread so fast, and it was miraculous, the change in Uganda's attitude toward AIDS and the willingness to take this, what to them was new, experimental, brought in by foreigners, but it was so clear that this is something that was needed in the country and was appreciated, was valued. And to this day, there's not a family in Uganda that doesn't remember the first years of PEPFAR. Everyone had a family member, a neighbor, a teacher that was brought back to life because of the early days of PEPFAR introduction of treatment in Uganda. And the fact that it was the United States that did it, that it was President Bush who did it, is always in that sentence. There's no doubt that that the United States has benefited from our initiative in doing that.
Thank you, Ambassador. So I think I also just wanted to find out how did you navigate that situation, but clearly it had to be not really try and error, but you had to show evidence of it using, and then that really showed that it can work, and therefore it was scaled up in that kind of scale that it was when the resources were available. Because we already encountered that narrative that it's not going to work in Africa. People are not, mindful of this and that, but clearly that case of Uganda showed that it is possible and with data, and hence it was basis for the scaling up globally now, not just in Uganda. Yeah. So I guess we can attend to the question that I had asked before, when I thought you had exhausted your answer. Like, so post that, putting systems in place, making sure that everything is there in preparedness to receive the resources and scaling up the project. What was your role as ambassador, and what did you really do?
Well, as you can imagine, CDC and USAID had existing programs, existing contact networks, and in fact came with competing proposals as to how to scale up, which of course would emphasize their expertise and their existing contacts. And I did have to make a little bit of a Solomonic decision saying we would do both. CDC wanted to scale up through existing TASO facilities where people were already getting care short of treatment. And CDC wanted to work with JCRC and the Ministry of Health to make regular clinics the place where you got antiretroviral treatment. And we did have enough money that we were able to at least start both programs. And I have to say that because TASO was so good and because CDC had such a good relationship there, I thought that that was probably going to be our more successful intervention, and that it would be difficult to work with the Ministry of Health and JCRC, which was not really on the ground in the communities. But Amy Cunningham of USAID, who's a marvelous person, I hope you get to talk to Amy. Amy Cunningham, with Peter Mugeni, devised a plan in which he said, within a year, we are going to have 21 health clinics in different parts of the country, ready, able, and underway giving HIV treatment, giving antiretroviral drugs to people who qualify. And I rolled my eyes and I said, boy, that is so ambitious. How can you do this? The Ministry of Health was not well led. It was not a performant organization. They had huge staffing gaps. They had almost no money of their own. It was led by officials who were later indicted for, and in a couple of cases, jailed for corruption. And the Global Fund had the problem of dealing with these Ministry of Health people who did steal their money. And so I was reluctant to put all of our eggs in the basket of the Ministry of Health. And the PEPFAR money did not go directly to the Ministry of Health. Those clinics were financed via JCRC as our agent. But Amy and Peter turned out not just to be right. They had promised 21 clinics. Within a year, they opened 27. Again, I'm joking. If you could imagine that we actually succeeded, where I, for one, was a huge doubter that we could ever get this done. In Uganda, there were conflict areas. There were areas that the Ministry of Health really had very little writ and very little personnel. But we were able, because AIDS was so important and because we had such good leadership from Peter Mugeni and in this case USAID, Amy Cunningham and Rob Cunane, we exceeded our targets. And we were able, both programs turned out to be on very, very strong footing. And as I say, we were able to reach, we think in the first 2 or 3 years, every person who at that point, by the criteria we had at that point, qualified for treatment. Treatment was accessible to them. Not all of them took it up, but tens of thousands of people, even in the first months, that first year, were able to access treatment.
Thank you, Ambassador. I think I want to talk a little bit about, you are the key person now on the ground in Uganda to make sure that this happens. You have to, I believe, work with CDC, you have to work with USAID. Now there's going to be PEPFAR. So how do you set up PEPFAR? How do these three organizations work together, agencies rather, work together? And what was the experience in like the initial work to set up and to make those work
No, I'm
seamlessly
so glad you
together?
asked that question, because so many people who see PEPFAR from the outside, who don't understand it very well, just assume that this happens. That was the key question of why I needed to be involved, or ambassadors needed to be involved. Mm-hmm. And that even before anything came out of the field, even before that trip by President Bush in July, I heard from John Lang, who was working with Ambassador Tobias as one of the deputies in the PEPFAR program the very first year, that the disputes, the competition for resources between CDC and USAID, and also Department of Defense, Peace Corps, refugee programs, everybody who wanted a piece of what was now a large pie of money, became almost paralyzing to the office in Washington, that they didn't know how to resolve this. And Randy Tobias said to John Lang, who was then one of his two deputies, John had been former ambassador in Botswana after the time I was DCM there, but had come back from Botswana fairly recently and knew AIDS very well, knew Africa well. And Tobias said to John, we've got to get our people into the field, and it has to be someone who's very senior and can tell USAID and CDC what to do and keep them from fighting with each other and just make that decision stick. Where are we going to find these people for 14 focus countries? And John said, well, actually, you already have them. They're called ambassadors. And they could do that. They supervise USAID and CDC. They're under Chief of Mission Authority. And he was the one who put ambassadors in this position to resolve the disputes. And I have to say, it became very hard when resources were straight-lined. At that time, we had a huge influx of new resources. And so I was able, and my deputy, Don Teitelbaum, who's a brilliant collaborator in this as well, were able to essentially negotiate where everyone got more. They just didn't get everything they wanted. And that enabled them to get on with it and not worry so much about turf or so much about who else was getting money. But that issue and in Uganda we just had, because of the personalities, we had USAID and CDC people who knew each other, had been working together, got along. I remember one example where someone from CDC said, well, I really can't argue with, I can't remember the name of the person, with Brittany, because she's my third grader's room mother. And there was just that kind of relationship which you have overseas in country teams and in staffs at embassies abroad that you don't have in Washington. In Washington, it's a zero-sum game, and agencies are competing for resources and influence and policy decisions. You actually can find win-win situations in Uganda, especially where resources are increasing and are seen as generous. But that was a huge issue. And as I say, they had different strategies to how we would scale up treatment in Uganda, which was the key requirement of the program, and very little guidance from Washington. It wasn't that they said, oh yeah, this is the right way and this is the wrong way. It was up to the ambassador to kind of make those decisions. And I loved that. I thought that was how embassies should work. But it was atypical. It was the first and probably last time that's really happened.
Could you please, Ambassador, explain to a layperson like me, what was the reason for these disputes? I mean, why were they not working together? Was it because of a new baby coming into the family that they don't know? I mean, what was the nature of these disputes amongst the agencies?
That would be worth a separate whole series of interviews and articles, and I'll give you my impressions. One is that since the 1950s, USAID had been working in global health overseas. It has no domestic mandate. It works only overseas. They had long-established programs, relationships with partners in countries like Uganda. CDC had very few people abroad. They had only 3 centers where they were working on HIV before PEPFAR full-time, that were CDC-run operations, and those were in Thailand, Cote d'Ivoire, and Kinshasa, Congo. But because of PEPFAR, because of the AIDS program, they started assigning more people overseas. And with PEPFAR, that number jumped dramatically. So CDC was seen as a newcomer taking over turf that USAID thought was theirs. And the way this program was designed, there certainly were rumors, and it appeared to be the case in practice, that President Bush and the people at the White House didn't really trust USAID to run the program. The previous program under the Clinton administration, called the LIFE Initiative, was USAID and DOD, but not CDC as main implementers. And I think that just because of the constellation of people who were in the room when they made these decisions and advice from Tony Fauci, they wanted to get the Department of Health and Human Services, especially CDC, more involved in the implementation of this program. And so they had opposite strengths. USAID knows how to move money quickly, but they do that by obligating it to contractors, to third parties, cooperative agreements, to grants and so on. Whereas CDC has expertise in person. What they do is send out their own people who are the experts, and they, of course, have a comparable role in the United States. So it's a much different culture. It's a different way of doing that. CDC is very poor at moving money. It's really a nightmare for an embassy to work with CDC. To purchase a refrigerator for their units it requires chief of mission involvement and many, many negotiations with headquarters. Whereas USAID, this is something they do every day, and embassies do this regularly. So they had complementary but different sets of skills. And then on the actual programs, USAID's comparative advantage was on behavior change communication, testing, things that are done for individuals and not necessarily in clinics. Whereas CDC is a biomedical organization, so giving drugs, doing tests of whether the drugs are working through sophisticated hospitals is the way CDC does its work. They had in Uganda adapted and used TASO as their partner, which is of course a community-based organization, so they had overcome some of this. But the idea that the different strains of PEPFAR, the protection of orphans and vulnerable children, clearly USAID would have the lead on that because it's something they were working on. It's not a biomedical question. And the prevention programs, especially because we were on the Ugandan model working on ABC, abstinence, be faithful, and use condoms, these were areas in which USAID had a number of partners who'd been working for a long time on prevention strategies using this behavior change communication of public health messages. Whereas suddenly treatment was something that CDC was actually better at. USAID had not been in the treatment business. Uganda, they had a track record through this Tororo project. But, and as PEPFAR developed, this became even more pronounced because as prevention of mother-child transmission became one of the big successes and foci of PEPFAR, voluntary male medical circumcision. These are biomedical procedures in which USAID, behavior change have a role, but CDC had the partners who were doing that. They had the expertise of their own staff of people who were doing this in the United States and therefore could project that expertise in their programs overseas. And CDC scaled up from, at the turn of this century, had about 50 CDC employees working under Chief of Mission Authority abroad. By 2011, when I joined Health and Human Services, they had 480. So they had multiplied by a factor of 10 the number of Americans they had overseas, and over 2,000 employees, including local hire staff. So CDC scaled up for PEPFAR. They were PEPFAR-specific assignments, and they had a particular role which turned out to be the most successful part of PEPFAR. I mean, the treatment, we were able to measure results, we were able to expand that program quickly and systematically, whereas the behavior change communication, protection of families affected by AIDS, orphans and vulnerable children, turned out to be difficult to implement, difficult to measure, not sure that we were getting the results that we wanted. We certainly didn't have the statistics that could prove that individual interventions were as successful as those biomedical interventions. And I think that the agency tension revolved in part by that it was the newcomer who had the programs, the skills, the comparative advantages that were actually needed for what was new about PEPFAR, and that clearly the legacy programs felt challenged.
Thank you, Ambassador. I think my next question that I want to find out after understanding the manner, the issue around the disputes and all of that, So you're working to coordinate the agencies, the USG agencies. That's one strand of your responsibility. Then you have multilateral. You're talking about Global Fund. And then also you have local organizations like TASO and JCRC. I'd like you to talk about that as well, because we've had JCRC featuring a lot with Peter Mungenyi, being one of the people that were really important, like at the beginning.
Absolutely.
Could you speak more about that aspect as well?
Sure. Again, I'm going to go back in part to your previous question. One of the issues also was that it wasn't just USAID and CDC who were entitled to some money under PEPFAR and were competing for it. And possibly the biggest administrative mistake that I made in my first year was that the refugee program, Uganda was home to, I think, per capita the largest number of refugees in any country in the world, and it's from South Sudan and from Congo. And the refugee program said, well, we'd like to start antiretroviral treatment with the refugee populations. And we talked a lot about it and the pros and cons, but because this was lifelong treatment, refugees were by definition not in their home countries. Neither of the countries from which these people came would be able to provide that kind of care if they went back. And because the refugee populations, although they wouldn't have been that difficult to reach, they were in settlements where they were there, were not part of the existing Ugandan system. The partners we would need to engage with were different than they were for the rest of the program. And I said, let's not help refugees. And I regret that. I think there was no medical reason, there was no logistical reason that we couldn't have solved those problems. And the fact that they were not likely to go back to South Sudan or Congo in the immediate circumstance meant they were Uganda's problem and therefore our problem for PEPFAR. And so I was glad that the second year the case was clear that we should include refugee populations in what we were doing. Finding a role for Peace Corps was challenging. Peace Corps, of course, couldn't provide medical services. How could they help in community education? DOD had a major budget of AIDS money under the LIFE program, and we actually did not increase their budget in the first year of PEPFAR, and that was my decision. And we got visitors from San Diego, which is where they were running their AIDS program, saying, we're not going to approve this budget globally because you haven't given us a proportionate increase, and so I said, well, tell me what you'd spend the money on. And they actually couldn't come up with much. They were already doing what they did military to military. They didn't have the resources to go beyond that even. They were already treating military families, but the clinic system in the Ugandan military wasn't up to the kind of expansion that was needed for PEPFAR. So there were interagency battles. The USAID CDC one was the classic and was over the most money and was the core of what PEPFAR was about. But these other programs, which were stakeholders in PEPFAR, were part of the interagency process, were also issues that the ambassador had to pay attention to. And I was, as I say, I don't think I was very wise in the way I handled all of them, but we got a program that worked, and eventually I think we addressed everybody's needs.
Okay, so please.
Anyway, I missed your question about multilaterals.
Yeah.
Just looking at the end, in my last few months at Post in 2005, I was there through September 30th, 2005. So it must have been the summer of 2005. The head of the Global Fund came to Uganda, and I'd known him because I'd been on the Global Fund board when I was at the PEPFAR office in Washington. But the chronology's wrong. So it was someone I had met because he'd been on the Thompson delegation. I did not yet know him from having been involved in the Global Fund. But he came to Uganda, and we made a point of saying he wanted to come by the U.S. Embassy, talk about PEPFAR, but we put our whole team in the room and said, your money's being stolen, and here's how they're doing it. And here the Ministry of Health is setting up these essentially fake NGOs who are recipients of your money and getting huge kickbacks from the people who are getting Global Fund money, and you don't have anyone in country who's monitoring this. And they refused to believe it. They actually punished the portfolio manager for Uganda. I would have hoped because the program wasn't working, but it turns out she had been telling them this for a long time and they didn't want to hear it from her either. And so they transferred her when they kind of got a confirmation of what they thought was her making things up from the U.S. Embassy. It put them in an impossible position. So our relationships with the Global Fund were in parallel, rarely actually working in harmony in country those first 2 years. That changed because of for a lot of reasons, in that the Global Fund was better at procurement than we were, and we were able to establish lanes as the programs expanded. WHO was fascinating. We had a wonderful WHO representative in country who was one of our biggest supporters, as was the UN AIDS representative, Ruben Del Prado from Suriname. And the WHO rep was from Nigeria. And I made a point of briefing them regularly about what we were doing. They were both fully on board. We included them in some of the meetings about how we would scale up. But their headquarters didn't believe it. They were very skeptical of PEPFAR, as you know. Mm. And I had a visit early on, I think maybe even before treatment started, from Jim Kim, who was then head of AIDS at WHO, talking about the 3x5 initiative, which was a very worthy idea of saying that by 2005, we wanted 3 million people on treatment. But his pitch, and he's not, like Holbrook, he's not a shy person or prone to understatement. His pitch was, well, of course this PEPFAR money is going to WHO so we can achieve our 3x5 goals, right? And here's why, and here's how you can't do it without us, and so on. And well, none of that money in Uganda went to WHO, a little bit to UNAIDS because they did a few education programs, but very minor. These were very minor partners in what we were trying to do. And we had a plan, and we had a plan that we knew would probably reach the most people in the most time, or at least had that ambition. And neither of those organizations had the wherewithal to actually reach clients for treatment scale-up. They didn't have expertise in orphans and vulnerable children. They didn't really have expertise in prevention either. Mm-hmm. And so we did see them as allies. We kept them informed. They were important when we set up an advisory committee within the Prime Minister's office to be the government's counterpart, because very little of the money was going to the government, but we needed government approval for everything we were doing. And so we carefully chose some experts led by the Prime Minister to be our advocates within State House. President Museveni was permissive. He didn't stand in our way. He let us do what we needed to do, but he was never the champion of the PEPFAR program. He was a little bit skeptical. It wasn't through him. He and his family expected an equity share in most things that were going on in Uganda. They didn't have that in PEPFAR. Mrs. Museveni tried, and one of her organizations was originally funded, but actually that funding expired as they weren't able to produce the results that they had promised. But in the orphans and vulnerable children side, the protection of families affected by AIDS. But we did have strong support, and there was an AIDS commission. So the AIDS Commission, Prime Minister's Office were our main government contacts. The multilaterals were included in those fora where we had government advisory committee on how we should do things. And they gave us good advice from time to time. There were some things that we needed to pay attention to that we were ignoring. But I can't say that there were any major changes, of course, because of the opinions of any of those, neither the Ugandan Advisory Committee nor the multilateral organizations.
Mm-hmm. I was actually going to ask about Mrs. Museveni, like her role. Do you recall there was any role in trying to like in the HIV response field as well, like generally? Was there any role she played? And because also Peter, we've heard quite a lot that he was quite an important figure as well, Mungenyi. So I just wanted like a much more context, a type of experience that you had with them, if this is the case, since you were the ambassador on the ground.
Yeah, she was very engaged in HIV, to her credit. She saw the problem, as her husband was. They talked about it publicly. They drew attention to the risks and risk behaviors that produced HIV, and the President Museveni is famous for the expression about zero grazing, and he took HIV very seriously because when he first took over, they sent about 80 military people to Cuba for training. And Cuba at that time was ahead of many countries and actually tested all of them for HIV and sent more than 30 of them back saying these people have HIV. These 80 troops in 1987 that went to Cuba for training. And he said, Castro said to him personally, you've got a problem and you yourself need to pay attention to this. Because if you have 40% of your troops with HIV, you've got a huge problem in the country. And so he said, from that point, he took it seriously. His wife took it seriously. They both were evangelical Christians. And of course, many of our partners also were from that community. And the faith-based organizations
going to be my next question. So
had good relations with Mrs. Museveni, especially Shepherd and Anita Smith, who were very active in Uganda on behalf of their Children's AIDS Foundation, I think it's called. And so through the Smiths, one of the Orphans and Vulnerable Children grants the first year did go to an organization which Mrs. Museveni was the honorary chair and an active promoter of that organization. And she, of course, was very strong in the A and B messages of abstinence and be faithful, anti-condom use, but eager for putting up billboards about sexual behavior and supporting organizations that were trying to promote abstinence. And that was one of our mandates, and so we worked with them. Again, the questions I would ask for any partner organization, especially U.S. people coming, how does what you're doing fit in with the national strategy? Who's already doing this in the country, and how are you going to add value to their efforts? And what results can we see in 2 years? And even though Janet Museveni's organizations were obviously of Uganda and had lots of, were local organizations, they didn't in fact work well with others who were working on the AIDS education part and wanted their own agenda rather than trying to see how their agenda fit in with ours. And so they turned out not to be important partners in the implementation of the program, but we made a point to be sure that she was informed of what we were doing, that her messaging about behavior change was, we hoped, consistent with the science and consistent with what PEPFAR was trying to accomplish. And I think there was a bit of competition. I think they saw us not using the First Family as our main partners in the country as suboptimal from their point of view. But we were getting such results, and there's no question that their country had such a problem that needed this intervention that they made the correct political judgment that there was they couldn't be seen as standing in the way of what President Bush and the U.S. were trying to do. And of course, the Bushes themselves had talked about their Christian faith, had strong support among the U.S. counterparts to the evangelicals in Uganda, and both of those were assets to us as we were working with a lot of organizations in Uganda. There were many, many Christian organizations, as well as Muslim physicians were one of our partners. Interfaith Council was one of our partners. Catholic groups were partners, but the evangelicals and the missionary communities were especially important and central to what we were doing, and we saw them as key implementers.
Thank you, Ambassador. I'm going to move into more of implementation phase, especially once the funds for PEPFAR had come through, so there had to be partners that were picked, some maybe existing, some new. How did that work? Who was picked and what criteria was used or decided upon for who has to get their hands into the funds of PEPFAR?
Of course, after the President's speech and when the kind of terms of engagement of PEPFAR became clear, there was a year before any money actually arrived, which is in March of 2004. And during that time, everyone, and I mean everyone in the AIDS world, was asking, when's the money coming and who's getting it, and can we be first in line? And the squeakiest wheel, by far, was a doctor, a Danish doctor named Margaret Juncker, who's still in Uganda. She was married to an American, she is married to an American, who was the World Food Program representative in Kampala, so we knew them very well. But she, being a physician and having to follow her husband's career around the world, had found a job as a physician at a Catholic clinic that was in a very poor part of town and where the need was great and had not been established. It was on the grounds of a church and was a small operation, had not been founded as an AIDS organization, but was overwhelmed with HIV positive patients. It was a community kind of based hospital called Reach Out Mbuya. And Margaret, who is a force to be reckoned with, and you might interview her just because it's such a vivid memory for all of us, really had Jonathan Merman on speed dial, and she would be calling him every other day saying, when are the drugs coming, when are they coming, when are they coming? The first drugs that came were airlifted into Uganda because we'd been so far behind. And it turned out to be one of those days she had called and she said, we absolutely need them today. We have people who are going to die if they don't get these drugs. And so the very PEPFAR patient number one was at Reach Out Mbuya, was her choice of patients, and his name is John Robert Ngole, E-N-G-O-L-E. And John Ngole was a high school teacher in the eastern part of Uganda who was kicked out of his community, divorced by his wife, rejected by his family because he was HIV positive. And he ended up at this clinic, penniless and destitute and desperate, and had a CD4 count of 2. And if you know, that's the immune system in your body. So if he had caught a cold, he would be dead. There was no way he was going to survive if he didn't get treatment. And so she picked him as the first recipient of the antiretroviral drugs. And to speed into the future, he not only survived, he thrived. He became a tutor for other people at the Reach Out Mbuya because he was there for several months. It took him a long time to recover, but he went back to teaching. He got a master's degree. He remarried. He has children, new children with his new marriage. He's been to the White House. He was at my residence in Kampala. He's met everybody. Met the Bushes, met Hillary Clinton. And when we were at Reach Out, so I asked Margaret in subsequent years, how did you pick him? He hadn't been at your clinic the longest. She said, he wanted to live. And I thought, again, I was choked up. The idea that someone wanted to live and had the chance to do that and became such a contributing member of society, someone we could all point to and say, here's a person who genuinely would have died within days had he not been treated with the drugs the U.S. provided. So we had planned out, we had time to plan out where we would start, who would get initial drugs, who the partners would be, what criteria we would have for selecting patients and so on. And that plan was implemented once we were able to get the supplies.
So I know also, I don't know if this was the issue from the beginning, whereby you have U.S. NGOs coming into different countries to help and bring expertise so that we are able to implement the different interventions. Was this the case in Uganda or not?
If you were an organization interested in global AIDS in 2003, you had to be in Uganda. And every one of them came, and I think I saw 90% of them. Okay. And again, I ask these questions: how is what you're doing fit in with the national strategy? Who's already doing what you're doing? How are you going to add value to them, not compete with them? And what results can you see? And some of the most well-known, big, famous NGOs could not answer those questions, and some faith-based, some small ones, some entrepreneurial NGOs gave good answers to those questions, and many of them were able to get funding from PEPFAR because we had a lot of money. On the other hand, the the kind of AIDS industrial complex that developed because of PEPFAR, the number of people who were attracted to the money and certainly had some skills, but whether they were skills that were relevant to the country where they were being used, I think was an open question. And we had, for instance, $2 million had been identified, and this was a country team decision to help with the health information system in Uganda, which was entirely inadequate to the idea that you were going to have people on lifetime treatment in the eventually hundreds of thousands, and they simply needed a system to keep track of them and some kind of electronic records keeping and so on. And the person who came and convinced the Ministry of Health and our partners that he had the best system was someone who didn't know Uganda, hadn't really worked in Africa, was selling an IT service, health information management, and I met with him several times. I say maybe I'm misremembering because of the ultimate result. I was dubious that this was the right partner, but he made a very effective sales pitch, an American, got the contract, and the system was abandoned within 2 years because the people in the field could not master it. It didn't deal with their reality of how would you collect information and report that information. It replaced everything that they were already doing, which they were doing not just for AIDS patients, but for other patients. And the system turned out, for reasons I didn't even imagine at the time, but turned out to be utterly impractical. And so we wasted that money. And I'm glad to say I wasn't the one who recommended this contractor, but there were, as you say, there were people who, with products to sell, who saw PEPFAR as the pot of gold that they could take advantage of. And some of them were successful, and some of them for good. Some of them did great work, but in this case, it was someone who, in fact, wasn't the right choice for the purpose.
So, at what point from 2004, when the funds started coming into Uganda, were you? I don't know how long you stayed right after that, but at what point was the impact showing, like in a way that, like, this is really working? It's no longer like a try and error thing. Like, when was the game changer? At what point? After how many years were you able to see the impact of PEPFAR coming into the landscape?
Anyone who had been to Tororo knew it was a game changer.
Okay.
And so I'm not sure there was a epiphany, that there was one moment in which people in Uganda said, oh, we know this works. Because they already had that example of it, and the antiretrovirals that were being given in Tororo were amazing. And Becky, when you talk to her, one of the things I just learned this year from her was that they already knew from the people who were on antiretrovirals in Uganda in discordant couples that there was almost no transmission within these couples. And you know, somehow treatment as prevention, or U equals U, is something that's just been in the last 10 years. But in fact, they knew it already in 2002. And so it's kind of fascinating that we knew even more than we knew, and we weren't writing this up, we weren't drawing conclusions from it because it wasn't the purpose of the intervention. But we learned a lot. So the people who, it depends, kind of, there were, you know, core and then different orbits of how people knew about things. And I think it really took probably a year before that phenomenon I talked to, that everyone I knew, every policeman who was guarding the route, or local employee of the embassy, or someone, if you went out to a village, would say, how can I get my friend, relative, spouse into treatment? And it became something everyone talked about and everyone knew about. And it probably took about a year from the introduction of treatment in 2004. But there were some people who knew right away, and certainly those who were affected became our best ambassadors.
COP process is one of the very important aspects of how PEPFAR funds were administered. So could you explain to us, like, and walk us through the COP process? I believe you're aware of it and you're involved. So how did that work out?
I can't, because we didn't have COPs when I was there. We had, we were allocated an amount of money. Okay. And the first year I think was $80 million. and we were to present a program, so it's what became the COP. But we did this through a very informal process without any, I would say, I think headquarters were talking to their staffs in country like USAID, DOD, CDC, but there was no moment at which the agencies said, we're in this today or this week going to sit down and just divide up the turf and talk about that. We had an iterative series of discussions based on how are we going to spend this 80 million. And there were some rules, including that you had to go through legacy programs, talk about track 1.5 programs that could be scaled up the first year to include treatment, which didn't already include treatment. We had to decide if any of our legacy programs that were funded by AIDS money were not applicable to PEPFAR, and we did find one that had to do with agricultural, there were crop improvement programs in which they had an AIDS education component, which we said wasn't really what PEPFAR was trying to do. So we actually stopped money going to one of our USAID contracts. But so we had those sorts of discussions interagency, and I have to say that I was the decision maker on all of on those people. Many times there was consensus, but a number of times there wasn't. And the most vivid memory of the non-consensus was whether to continue the AIDS program, which we had through our private sector support activities of USAID. We had been financing a handful of employers to provide HIV services to their employees, education, but also medical services. And the particular case in point, some of them were in remote locations like the cement plant that would go ahead and become a center for others. But the brewery, which was, I think, Kampala's biggest employer, one of them at the time, was their medical clinic was located a kilometer from one of the centers that Tasso had set up that was being financed by CDC. And it was a USAID program helping these private sector firms provide AIDS services. And CDC made the argument correct from a public health point of view that these are not indigent people. These people could get to the clinic a kilometer from where they worked. They were an easy audience to reach, and we were providing duplicative services by having the brewery, which was not as well prepared for a comprehensive program as a medical clinic would be. The USAID made the argument, which I accepted, which is private sector involvement in the fight against AIDS is going to be crucial in the long run, and that these people, this program is successful, people have confidence in it, they're already enrolled, and to abandon it at this point would send exactly the wrong message, that somehow we don't want your partnership as the brewery, or that you employees of the brewery are second-class citizens and you have to go to somebody else's clinic. And so we continued that program, even though from a public health point of view, it probably didn't make a lot of sense. And those are the kinds of decisions that we made in the sort of virtual COP that we had. And the decisions were accepted. There was a later decision on what would happen to the cohort that was at Rakai. As you may know, Rakai was the place where Tony Fauci has his lab. It was the epicenter of the first SLIM outbreak in Uganda, down on the Tanzania border. And Columbia University, Johns Hopkins, and NIH had a very sophisticated cohort study of thousands of people in Rakai. I think there were 15,000 people in the cohort, where they did a lot of original research, very important fact-finding about how the epidemic was spreading, who was most vulnerable, who was being protected, what were the effective factors in protecting people. But this cohort, clearly, who'd been studied for a long time, deserved priority attention for treatment. And there was a dispute between Debbie Birx, who later became PEPFAR coordinator, who was then the DOD's lead for part of the DOD program, and she'd been from the vaccine end of it, but had been active in Uganda and was one of the researchers involved in the Rakai project, knew all those people very well, and came up with a very well-written 75-page proposal of how her organization should be the ones to provide the antiretroviral treatment to them. CDC, which you could talk again to John O. Merman about this, was also had relations with Rakai, and they, combined with the McCary University School of Public Health, which had founded the Rakai Project some years before, had a counter proposal saying that they would provide the antiretrovirals through the existing public clinic using McCary University as the main partner. And this was a tough decision, but I did opt for the CDC proposal. Debbie Birx has, I think, never forgiven me for that. I think she rightly believes that she had the stronger proposal, and it was a political decision that I picked the other competitors. But it worked out well. Either of them would have done fine, and the military program was actually then given the lead in another district where there was a smaller cohort study and where they could develop their own cohort for other kinds of studies. So they did get the equivalent amount of money they would have had, but the prestige of being the provider in Rakai went to somebody else.
As we wrap up your experience within PEPFAR directly implementing in the field as ambassador, what could you say is one of your proudest moments in that type of work that you have done for PEPFAR in Africa, for instance?
I'm not sure it was a moment. I think if I look back, what I recognized, and this was partly self-serving, was that ambassadors and I, as chief of mission in Uganda, had resources and ability to connect some dots which the other PEPFAR partners didn't have. That I had a vision of how this could work and who could be involved, and again, some of these political priorities, which I thought were important to the success of the program, would not have been decided the same way if this had been just done by technical people. And that the role of diplomacy in advancing public health goals is something that I hadn't thought much about before. I did think about it when I was in Uganda, because I realized that's what I was doing, and that I saw individual examples of where these people just don't get it. We're going to have to do it a different way to make this sustainable. And then it became my career. I mean, PEPFAR influence affected thousands of lives, and mine was one of them. And I just realized that there was a pond for health diplomats, AIDS diplomats, and there were no fish in that pond. And that because I'd had this experience and because it was so successful, I could certainly live off of that for many years. But that it wasn't a moment at which I said, oh, this is what I'm proudest of. Certainly getting the John Ngole onto treatment was a moment that will live, and the sense of President Bush in the car, I've repeated many, many times. So yes, there were things there were individual moments that are unforgettable and are highlights and should be part of a PEPFAR oral history. On the other hand, the sense that no one had actually thought of why diplomats were important to the success of a program like PEPFAR. And I was glad that I was able to be the person that demonstrated that. And this really was immediately recognized. I mean, I was brought back to Washington when I finished in Uganda, in part because I had been the ambassador who was able to articulate what we were doing, to put it in context, to say why this was a U.S. interest, say why we were accountable for results and what kind of results we were getting. And I'm very proud of that.
Fast forward to OGAC as Deputy General. How do you leverage your experience from Uganda as you come into the office of Deputy Director at OGAC from 2005
well,
to
John
2007?
Lang had the job to which I came in as the chief diplomat. Randy Tobias said, and I hope you're interviewing him. Are you going to Indianapolis or something
We
to
need
see him?
contact for him. I don't think we have. Oh, we do.
Okay.
Okay.
But he apparently said when he took the job, I want two deputies, one with the first name doctor and the other with the first name ambassador. And so John was the ambassador deputy and did some brilliant work in saying how embassies should be involved. But he had left a year before I got there, and there was a real vacuum. There were no senior Foreign Service people, no senior people who knew the State Department in the office. And part of it was just saying, this is the culture in which you're operating. This is how embassies work. These are some messages that you need to be sure you're getting across to the people you're relying on to implement your program, because they don't know your language. You're going to have to teach, a new language and a new culture to people who, for whom this could be a learning. There might be a long learning curve, and there was. And our relations, we had paid very little attention to multilateral organizations. Some attention, but not very satisfactorily to civil society. And one of the first things I did when I got there was say, in Uganda we're required, or at least we're expected, to have a meeting with civil society twice a year to talk about how the program's going. And both because it's useful to us and because it's very important for them to stay on board and know what we're doing, those meetings paid off. I said, why aren't we doing that in Washington? So one of the first things I did was to set up a meeting of civil society, and by design, I said, we have to have everyone there. We can't be saying one thing to the faith-based groups, another thing to the private sector, another thing to the AIDS activists, gay rights organizations, and treatment action people. And so we had them all in one room, and they were very polite. They asked tough questions. They asked questions that reflected the point of view they brought into the meeting. But those I think became an important part in building PEPFAR's kind of foundation in the U.S. because at the beginning, as you remember, PEPFAR was being condemned by most of the activist organizations because thought it was just to buy brand name drugs, that this was being run by a pharmaceutical executive. We didn't have a lot of people living with AIDS involved in the program, and that they said this is a hoax. This isn't really what we need to combat the epidemic. And we won them over. We won them over by action, certainly in Uganda, the 2 years I was there. But by the time I got to Washington, there were still some holdouts, and we just needed to engage them and show them what we were doing. And in some places, we got off to a very slow start. In some places, in 2 years, we didn't have any results to show. The other thing that I did was I was then sort of engaged with the Global Fund, with these donor groups, with the World Bank, and I was the person who attended their meetings. And when I remember the first Global Fund kind of conference I attended, I was in a room and a guy, another participant there, an American, but working for one of these multilateral organizations, just said, "Oh, what a tsunami of fresh air that somebody has come from the field, who's actually working on this program, knows how our organization works, knows how PEPFAR works, and is able to have a dialogue with them about how we could work together." And in fact, in the first 2 years of PEPFAR, those dialogues, if we'd had them, hadn't paid off. Those organizations didn't feel as though they were stakeholders in PEPFAR's success, and had to kind of imagine for themselves how the programs intersected. And by having worked with them in the field, knowing what their goals are, and being able to explain PEPFAR and where they were important and where in fact they weren't important or weren't doing their part, I think we got onto a much better relationship with the multilateral organizations. And if there were proof needed of that, at one of those meetings where they had all these donors gathered, the fellow who's in charge of AIDS at UNICEF, who I'd gotten to know through that forum, just said casually, "It's been wonderful working with you all. This is my last meeting. I'm leaving UNICEF." And at the coffee break, I asked him just completely randomly, "Well, who's taking your place?" And he said, "Are you interested?" And I said, "Well, I never really thought of it." And he said, "Well, the deadline is like tomorrow for applying." He said, "I really like you to apply. I think you'd be the right person." So I went ahead and spent the night applying, heard nothing for 3 months. And I said, well, okay, that was a waste of an evening. And suddenly, the Friday before the 4th of July, I get a call from UNICEF saying, "We have to interview you for this job." And I have an interview. And then I hear nothing more for a couple of weeks. And suddenly, Ann Veneman, the head of UNICEF, who had come to Uganda, among the people coming to look at AIDS programs in Uganda when I was there, I'd been to a dinner for her and we'd had a conversation, so she knew who I was. It's coming to Washington. Can she have coffee with you? So I said, sure. And so come to this coffee, and she has these papers out there, and she said, well, this we're going to keep over here, but you're going to be responsible for this. I said, wait a minute. you're acting as though I'm working at UNICEF. Am I being offered this job?
Spit it out.
Oh yeah, didn't anyone tell you? So it was that crazy, but the sense that somehow PEPFAR and I myself were able to bridge some of those organizational gaps was important to my time there. The other thing was I was the only person who was a member of both the deputy principals and the principals, if you know those terms. This was the technical leads from the agencies and then the kind of politically appointed people. And I did use that position in ways that I thought were important to advance the program. I talked about my field experience and I was very much respected for that. All of them had been to Uganda, all of them knew that we had at that point the most successful program. But one of the things, and the staff of the office knew that I could sometimes raise issues that weren't very popular with some of the other agencies or principals. And the one I remember was about nutrition. That there was no question that the biggest need of the people who were on HIV treatment was food. They were metabolizing calories much faster than they did when they were sick. And there was no food aid component of this. And Ambassador Tobias, who always had this, and this is what we're working on. There are all these other things that are important, but this is our focus. Just said we're not in the food aid business, and it would be complicated to get into that business. And so there was one proposal for one of the annual strategies that said that we could entertain proposals for food assistance where it directly benefited the people who were already our clients, HIV. And it was just if applied for, but that wasn't ruled out as part of what then became the COPS. And I had the nerve to propose that and got a couple of people saying, no, we don't do that, or that, this isn't what I do, and particularly CDC and HHS didn't like that because it wasn't in their jurisdiction. But it got approved, and it changed PEPFAR. I mean, the idea that once Eric Gooseby took over, the doors were opened probably too wide, but the sense that we didn't just do prevention, treatment, care, and support 24/7 was a breakthrough in how we envisioned PEPFAR, and the idea that we were listening to our customers and responding to their needs for nutrition was something I thought was important and was able to change the course a little bit of PEPFAR in my job there. But I was head of the part of the office that dealt with Global Fund and UNAIDS, and that's where Colin and Tracy were were the heads respectively in our engagement.
One last question, Ambassador, based on your professional experience. PEPFAR is supposed to be reauthorized, and we know that there's been different types of, discussions about reauthorization of PEPFAR. So what do you think is pushing this, and what are your thoughts about these processes in these kind of debates based on what PEPFAR has done before and looking forward with this particular feature that is probable if the authorization doesn't happen?
Well, first, PEPFAR doesn't entirely depend on the authorizing bill. It's a statutory body. There's a statute that puts it together. As long as they get appropriations, the fact that the authorization has lapsed will not in fact impede the ongoing program. And what it does do, it means that the kind of political consensus behind the program is eroded, and you can't do new things. I mean, the authorization is the authorization. It authorizes you to do different things than you've done before. And the original authorization that changed, for instance, the earmark that required money to be spent on abstinence and being faithful became a recommendation, which was monitored and was still important, but did not require every post to do that, where in some posts, like in Asia, it was not a particularly relevant program with drug users and so on. So the idea that the authorization is a very important milestone in looking at PEPFAR's progress, seeing how it needs to be changed, is important. The last couple reauthorizations have been just date changes. The program, they didn't want to open up the substantive part of PEPFAR to changes, and I understand that. I think politically that was the right decision. But if in a perfect world, we're in a different world than we were 20 years ago, a much different world. And the idea that PEPFAR does have implications for outbreak response, for health security, for health system strengthening, we've realized through the operation of PEPFAR. And de facto, PEPFAR is engaged in those sectors, even if that's not PEPFAR's reason for being or the main emphasis on its money. Its money has had influence and has been able to benefit the world there. But there really aren't rules. I mean, each decision is sort of has to be a one-off because there's no legislative mandate that says this is how PEPFAR should deal with a COVID outbreak or an Ebola outbreak or with questions about lab capacity or health system strengthening or local manufacturing. All these things are really important issues that PEPFAR can play a major role in, but it's a judgment call and it's always subject to political second guessing. So an authorization bill that tried to define better how we deal with this decade of the 2020s would be very helpful. And also in terms of the fact that it is a disease under control in the majority of our focus countries, that we can see the end point of our efforts. It's not an emergency, but it's still a high priority. And if we stop, all hell is going to break loose. We can't stop the PEPFAR program. But the idea that we're just going to kind of inch our way in baby steps into the future is suboptimal. This is not going to work. We have to be a little bit more creative in how we're going to sustain the programs we have, keep people on treatment, and build on the successes we've had. And then in those countries like South Africa, Mozambique, Nigeria, where we're not on track for epidemic control, how do we change the program? What do we do differently that can work? So the authorization is important for a whole lot of reasons. It's not existential for PEPFAR. PEPFAR will continue to exist even if there aren't new authorizations.
Thank you so much, Ambassador. Last question, as we're about to run out of time. Yeah. Oh, yeah. You want to have a follow-up? Go ahead.
Thank you so much, Ambassador. This has been a fascinating conversation.
And I regret that on film I'll have looked at my watch.
No. That's why they pay me the big bucks to look at my watch. One of the things that I wanted to ask is, someone who spent your career serving the U.S. and the world, how PEPFAR feels unique to you, to these other kinds of grand U.S. foreign policy visions. I was struck by when you said, President Bush said the money was coming and the money came, and that this was something that you had a lot of discretion under as ambassador, and you all took advantage of it in Uganda in ways that other countries didn't. And I'm curious the ways that PEPFAR feels unique when you put it in the constellation of all the things the U.S. has tried to do abroad.
PEPFAR is the best thing the U.S. has done abroad in my lifetime. I am honored to be part of it. I'm glad that I was able to contribute to it. I'm impressed with myself that I saw the opportunities that not everyone saw in the early days. But this was thousands of people, tens of thousands of people working together to achieve a goal which really was worth achieving. And since this is about the Presidential Center and the Bush legacy, I mean, he did this for the right reasons. This benefited U.S. interests abroad. Yes, it's a way we can distinguish ourselves from adversaries like Russia and China, who could never undertake a program like this successfully. But it also, we in the United States had a scientific breakthrough that allowed people to recover if they were infected by HIV. And 80% of the people in the world didn't have access to that breakthrough. And it took a few years, but we said, we as the United States want to be part of giving them access. This is important to everybody. This is just the right thing to do. And the fact that this was made on ethical grounds, not because, yes, there were militaries that maybe would have security problems because they had a lot of troops with AIDS, or there were economic consequences of AIDS. All these were known and important at the time, but that isn't why we have PEPFAR. We have PEPFAR because this is the right thing to do. This is the way we show our humanity, we show what America stands for, we show what our embassies can do, show what presidential leadership can do, what the wealth of the wealthiest country can do. And I wish there were more examples of this, but PEPFAR is the only one I know, and I couldn't be prouder. I think it hasn't gone perfectly. There have been some mistakes. There's some design flaws that if we started all over, we might do a different way. But I think it has proved the motive that President Bush had has been fully justified, and the implementation has been remarkable and remarkably successful. And there are many, many people involved in that. I'm glad I'm one of them.
Thank you so much, Ambassador. My second question before I pass it to Tandeka to wrap us up is, one of the unique things about this program that we've heard from people who were involved in the initial design phase was how much the Bush administration, in ways different from the Global Fund that you discussed, was really focused on antiretrovirals, putting medication in people's bodies as quickly as possible. But now when you look at PEPFAR, as you just discussed minutes ago, the program has really grown, and the kinds of work that PEPFAR does is really astonishing in ways that many foreign policy programs atrophy or don't work at all. Mm-hmm. And I'm curious, from your vantage point, having worked through that initial implementation and then seeing the transition to it becoming something bigger, what do you think drove that ability to see all the things that PEPFAR actually could do?
I think there are two parts of that question. One, PEPFAR was successful and hasn't atrophied because of presidential leadership and sustained financing. Mm-hmm. And I certainly in the world, because I now work in global health beyond the AIDS world, everyone wants a PEPFAR. There should be a PEPFAR for non-communicable diseases. There should be a PEPFAR for flu. There should be a PEPFAR for surgery. And all of those, wonderful if there could be, but there won't be. And the difference is that this had clear presidential leadership. He cared about this. He expected the agencies to perform. They did empower ambassadors. They empowered people in the field to make some decisions. We didn't have to wait for somebody else to tell us what to do. And the money was there, the money in significant quantities. It was a quantum leap from where we'd been before in other global health programs. All of those are going to be difficult to reproduce. And I think we don't want to overburden PEPFAR with saying it can be the foundation or the platform for everything we do in global health. That's not its role. It does have a disease focus, and that silo has advantages as well as disadvantages. On the other hand, I think I wish we had better guidance, better political support for defining what we're building on the PEPFAR Foundation to achieve. There's no question that the Ebola outbreak sucked a huge amount of resources into a disease which really only killed a few thousand people. And COVID then, we were planning for Ebola when COVID hit, which was worldwide, which affected advanced health systems, which has millions of victims. And the question of where did the PEPFAR fit into either of those was a hit or miss proposition, was done differently in different countries, was not recognized at headquarters, certainly in the US at the time of COVID, that the advantage PEPFAR gave to us in working in partnership internationally was never really realized. So there's a lot of thinking that needs to go into that, but it also isn't a miracle cure for health problems. It was a very successful proposal. It was right for its place and time. I think it would be a mistake to try to do something on that scale in the current political climate. It wouldn't have the same. It wouldn't have the same bipartisan support, and it wouldn't have the same budget.
Thank you, Ambassador. Very last question. This whole experience, very rich exposure, working in foreign service, different countries, different roles, before, after PEPFAR. So it has been quite illuminating what type of things you've been able to do and actually propose change that seems to have been effective. How has this experience really affected you personally and professionally, and even impacted your family? Maybe your children are working in global health or focused in Africa. I mean, overall, just to close us off with this interview.
Yeah, I think you've answered the question. It was life-changing for me. I was a very successful foreign service officer. I got to be ambassador twice. I won awards for political reporting. I loved what I did. I think I was kind of made to be a political officer and to do some political reporting and analysis, to live overseas, to follow politics, to write about it, to look out for U.S. interests. I love doing that. But this is different. This is something that is cross-sectoral, that directly affects the lives of people, that is definable. It's easy to have an elevator speech about PEPFAR. It's hard to have an elevator speech about what U.S. embassies do otherwise, what the Foreign Service does. And the past 15 years in which I've been working full-time on global health have been important to me, but I am disappointed that I'm still one of a very few diplomats, or American diplomats, who's taken this up. We don't have a core of people with diplomatic training who see health as a specialty they want to have, who have learned epidemiology as a second language. There just aren't many. And my goal, and the reason I'm back in the State Department working this new Bureau of Global Health Security and Diplomacy, is that we need a cadre of people. We need to multiply me by 20 and be sure that there are people in the U.S. Foreign Service and other foreign services who understand global health, who see its value to the U.S. relations bilaterally with other countries in terms of security, global security, economic security, human security, but also just that the outbreaks and epidemics are devastating, and we aren't prepared for them, and we're missing opportunities daily because our embassies aren't engaged on health policy, on public health issues that go beyond the technical cooperation that agencies like USAID and CDC have. And I think the State Department, Secretary Blinken certainly gets that. Deputy Secretary Sherman and Verma were very much on board and realized that we need to step up and play a role to engage diplomats in solving problems that diplomats are best at solving, but which have public health consequences. And that's still a work in progress. We are not even close to getting that to be part of our thought process when we're engaging in foreign affairs or when people are joining the Foreign Service or advancing their careers.
Thank you so much, Ambassador Kolker. It has been a wonderful time with you and so much great insight. And thank you for having us and sparing this time to be with us.
Thanks for letting me relive some of those experiences.